As Arkansas's population grows, so do our energy demands. But with the right mix of resources, reliable, affordable power will always be a reality. These resources are all around us in our rivers, blowing through our trees, even right below our feet. The answer isn't focusing on one resource, it's embracing them all. The electric cooperatives of Arkansas know that a balanced approach to power builds our communities and powers our dreams. Visit themixmatters.com and see why there's power in knowledge.
This is Talk Business and Politics with Roby Brock.
And welcome to the program. I'm Roby Brock. Glad to have you with us this Sunday morning. We start first with moves made in the healthcare arena this past week. On Tuesday, St. Vincent's parent company Catholic Health Initiatives acquired a Hot Springs hospital owned by Mercy Health for an undisclosed sum. The move expands St. Vincent's footprint into that region of the state. One day later, an announcement that Catholic Health will acquire Little Rock-based health insurance provider QualChoice. You couple those moves with health care reform, a March 31st enrollment deadline for federal health care, and changes in Arkansas's health care policies, and you have got a lot to diagnose. So here to help me operate and navigate through all this is QualChoice CEO Michael Stock. Thank you very much for being here. State Senator David Sanders of Little Rock, thank you guys for being here. One of the chief architects of the private option and certainly one of the foremost health care policy experts in this state with all your legislative activity. Michael, let's start with you first. Let's start with what this acquisition of QualChoice actually means. Is this going to be good for QualChoice, good for Arkansas? What are the advantages and maybe what are some of the disadvantages of this acquisition?
I think it'll be good for both QualChoice and Arkansas. As you know, CHI, Catholic Health Initiatives, one of the largest providers of health care in the country. They're in 18 states. And they have a plan to expand their footprint in financing health care. And they want to use QualChoice as the administrative center for doing that and run all their administrative operations through this.
I like the sound of that because that sounds like you're going to have to hire more people to handle more administrative functions, which sounds like high-paying jobs to me.
That's the plan down the road. I think there'll be expansion here.
What about expansion of the health insurance products that you have, opportunities for you guys outside of Arkansas in that respect?
The system is interested in both getting more involved in Medicare Advantage products and in the commercial market. They'll do that by looking, I'm sure, at other acquisition targets or by standing up new plans in those markets. And I expect us to be expanding into the Medicare Advantage products lines here in Arkansas.
Senator Sanders, you're all about competition in the marketplace. Yeah. This seems to be bolstering some competition here.
Well, it is. And again, if you look at sort of the traditional roles that insurers, healthcare entities, and doctors have played, I mean, so what we're seeing and what we have seen for quite some time is movement in how sort of the traditional players are organized and how they move forward. So I think this is a sort of an indication of what's to come, not only here in Arkansas, but I think nationally as well. So, CHI is a major player nationally. They have been doing innovative initiatives in healthcare outside of the state of Arkansas as well. And so it's I think it's a net positive, so long as what we try not to do is not to move with the market changes. You know, we have a tendency as policymakers and regulators to hold fast and hold true to how things were organized. Mm-hmm. This world of healthcare is changing before our very eyes. In fact, Arkansas is part of that change nationally, and so I think there's another reason for people to be watching Arkansas.
Is there anything from a regulatory perspective or a legislative perspective that you think might need to change to do what Senator Sanders is talking about, make this marketplace more competitive?
I mean, there are different ways to create competitiveness in the marketplace. You can do it either just with pure brute force and pricing, or you can do it by designing and devising alternative kinds of ways of delivering the product and care. And I think there are going to be those kinds of opportunities here. Arkansas has a law that deals with any willing provider, which makes it a little bit more challenging to create alternative ways of putting together networks of providers. But those kinds of things are developing across the country. Accountable care organizations are a phenomenon that is promoted and pushed through the Affordable Care Act. And I think you're beginning to see those develop here in Arkansas too.
Well, anything on your agenda?
Well, sure. And I think we have to be careful. So, I mean, we don't want to, in the name of innovation, throw out the baby with the bathwater, and that we just move and change things, wave things, make changes. I mean, St. Vincent was one of the lead proponents of Any Willing Provider in Arkansas decades ago. And look, I think it has served the state well in many respects. So I think what we need to do is every policy debate that we have and every conversation that we have about the regulatory framework, the legal framework is, we have to acknowledge that we are operating in a new environment and laws that were passed. And again, we're looking at this in terms of Medicaid, we're looking at it in terms of all kinds of programs that the state has. You know, a lot of the programs we have were created and contemplated in an environment where you didn't have the proliferation of coverage. So we're all moving together on this, and I think that's the important thing that we do, is that we're mindful that, you know, a move here it can affect something over here.
Let's talk about it. In Democrat Gazette this past week, there was a news report that highlighted QualChoice's kind of low-keying its participation in the private option. Obviously, that was by somewhat design because you had something bigger in the works there. A self-imposed cap of 1,280 plans. Senator Sanders, you said you might need some clarification on this.
Well, okay.
I'm going to give you an opportunity for some clarification here.
So I knew the fact that they had requested a cap. I didn't know that it was that small. Now, obviously, if they're in negotiations with a potential buyout, purchase, and someone else acquiring them, you know, the private option is a very innovative policy. And there's a lot of uncertainty in terms of that population, you know, utilization, you know, how they are going to adapt to something that they've never had before, and that is health insurance. So I understand that. I guess my hope is I do know that CHI and QualChoice they will be more capitalized. Mike, I look forward to you guys participating more in the private option. And again, we have information on the population now. So what was unknown is less unknown. There's still some uncertainty there, don't get me wrong, but I think there's an opportunity for QualChoice to participate and be even more price competitive.
Well, I think the answer to the issue, Roby, is, I mean, we knew that with insurance companies like banks, they have to be capitalized at certain reserve levels based upon the size of the business that they have and the volume that they have. With this large influx of new lives coming into the marketplace, QualChoice knew that we were going to add capital to the company to participate in that arena. In discussion with the shareholders, there was an avenue that was being worked to get there. We thought it was going to wrap up and be finished quicker, but in many times, you know, these transactions drag on.
You don't get to control those things.
You don't get to control the negotiations and the lawyering that goes into putting these transactions together. And so it took longer to get to the finish line where we want it to be. And because of that, the Department of Insurance worked with us to kind of control the flow of lives into the plan as that was being finished. And we hope that the whole transaction will close by the end of this month, and then we'll turn the spigot back on.
Well, so to your point about me wanting and others wanting more competition, right. I think what we have seen here and what has been demonstrated with their experience is that, one, we will work with carriers, and what you've seen, obviously, AM Better come into the marketplace. They're a new competitor. We want others. Mike might not want to hear that, and Blue Cross Blue Shield might not want to hear that. AM Better may not want to hear that. But in this ever-changing environment, we think, but again, Arkansas has the youngest pool in terms of its exchange in the country. We think that will be borne out as we begin to plan for plan year 2015. Some of the things that we're looking at with health savings accounts to encourage consumerism in healthcare, one of our favorite words. I think it will have an impact. But I mean, let it take note that Arkansas has shown that they will work with their folks, take a longer approach. What we wouldn't have wanted to happen is for the state to say, no, you got to be in. They couldn't have pulled it off, and then, it be, maybe not a failure, but it may have not have gone off as well as
we're hitting around the edges of some of this too. We're all talking about there's a lot of data out there now for you guys to make some more informed decisions. Obviously, we'd like to have more data. Mike, let me come to you on this. The goal of the Affordable Care Act was obviously to control costs. The private option was to control costs. The payment initiative that the state has embarked on is a cost control initiative. What are you seeing in the numbers? What's working, what's not working? I know it's a broad, vague question, but where do you see the data pointing you in the right direction? Well,
first of all, the amount of data we have right now is very small and still very immature, with the lives just coming on starting January 1 and claims beginning to be paid. But in terms of controlling costs and bringing down the cost of healthcare, one thing you have to remember is that insurance companies don't drive the cost of healthcare. We are financiers of the cost of healthcare. The government finances healthcare. The actual cost of healthcare is determined at the point of origin where it's delivered by the providers. That's where the cost is. And so what insurance companies try and do is work with those providers to make sure that at that point of care delivery, the delivery is as efficient and cost effective as possible. And there's a lot of things going on in the state, like the Arkansas Payment Improvement Initiative, patient-centered medical homes, episodic payments, to try and do those things and bring costs down and make the proposition more of a value-based purchase for the consumer.
But where are you seeing movement?
We are beginning to see movement. One, in the patient-centered medical homes, there's a demonstration project going on in the state right now that's being directed by the federal government. It's called the CPCI. All the carriers, along with Medicaid, are participating in that. We're seeing reduced utilization at the emergency room through that program. Episodic payments, we've seen so far in the first part of last year that the cost of hip replacements that we're doing in the state have come down a little over 2%, which doesn't sound like a lot, but on a big number, a couple percentage points can make a big difference. And so
that's a high reimbursement item too, as well. So that is significant.
Do you see things in this respect?
I do, and I look at it in terms of what are the missing components. And again, a lot of us, want healthcare to function like a marketplace and an open market and a freer marketplace. But in order to have that, you both have to have both quantitative and qualitative measurements, and that requires openness and transparency. And if you look at historically, you look at all the players in healthcare, the move hasn't been for openness and transparency in terms of quality and price. And those are sort of the missing components and sort of the what lies ahead on the horizon where we have to go from a policy standpoint. And we think that will benefit, because the truth is we will begin and continue to accumulate large portions of data, and what we need to happen is we need all of those involved. I'm sort of an equal opportunity skeptic. When an insurance lobbyist comes at me, a doctor lobbyist comes at me, or and quite frankly a hospital lobbyist, and a government bureaucrat even. So we have to look at everyone with guarded skepticism, because what has to happen is we can't operate in silos and do what is in our best interest, but we have to move the ball down the field, operating in the best interest of the consumer and the taxpayer.
Everybody's coming after you. Everybody's coming after you. Anyhow, gentlemen, we got more to talk about on this topic, but we're out of airtime for this. So let's take it offline or online to our website. We're going to continue our discussion online at talkbusiness.net and katv.com, so stick around. Now, we've got more news to get to in this week's show, including new poll numbers in the Arkansas governor's race. I'm Roby Brock. This is Talk Business and Politics. We're back right after this.
A farmer understands the needs of every season, and so do Farm Bureau members. When Arkansas families needed electricity, our members brought it. Reliable roads, our members built them. Agricultural education, our members provided. Today's members may not live on a farm, but their connections are as close as ever. So when that difficult season comes, no member has to face it alone. For every season, Arkansas Farm Bureau. Join today.
And welcome back to our Web Extra. We are conducting our healthcare roundtable this morning. State Senator David Sanders, Mike Stock, CEO of QualChoice. Thank you both very much for being here. Let's pick up where we were talking earlier. We kind of hit around the edges of consumerism and how important that is going to be to healthcare policy and to health insurance in the marketplace going forward. Are people going to be able to take more ownership in their health insurance? Do you think that they're capable of doing that?
Oh, I think so. I mean, they've already started to do that with HSA accounts. When you put your own money in there and it's pre-tax dollars, and then you use your own money to pay for your deductible and out-of-pocket costs up front. I mean, we've seen a lot of movement just in like the way people buy drugs when they have to buy their own pharmaceuticals and pay for that on high deductible health plans that are HSA eligible. Our volume of generic utilization is well up into the mid-upper 80% now, because people are paying for that out of their pocket.
And is that what drives the decision making on that? Because I think you've got an element of the population that is obviously educated enough and motivated enough to want to do that. You've got element of the population
Well,
that needs to be, but there's going to be an element of the population that is going to be challenged to understand
There are two
health
components. There are
insurance.
two components of that. So, to the extent that providers can assist in this move towards and drive towards consumerism, they need to, and in fact, they are. But I mean, there's nothing. You know, what has happened in the country for years is we have all become and have been, in a certain sense, continue to be users of healthcare rather than consumers of healthcare. I use generics as well. I mean, I see the same thing that everyone else sees. You know, what impacts my cost, and so what we're trying to do, and you see this with our efforts on the teacher and state employees health insurance, which if you look at their plan design, it has encouraged utilization. I don't think discouraged utilization in terms of the cost sharing structure. But even with the private option, I mean, you're taking a segment which has been completely isolated from the insurance market historically. Now we're putting them in. The thing is, we need to take this opportunity and help them become consumers of care. Let me give you an example. You know, one of our local hospitals, and Mike, you talked about it on the program, in terms of seeing ER utilization drop. Payment drives function and form within hospitals. We're seeing Baptist Health has talked about how they're seeing a drop off in their ER census. And why is that? One, because they've opened up a after hours adult clinic or an urgent care center, or they're assessing those who walk in the door to see, one, do you really need to be in the ER? Would you be better suited for our urgent care center? Or do we just need to get you and establish a relationship with a primary care physician and get an appointment made for you? Now, and they're doing that is because if someone does make it through and ends up in that ER and it's determined that they were there on a non-emergency related visit, their payment is different.
So this education is needed, but yet the legislature has pulled back on some of the education funding with the navigators.
No, that's not education, Robbie. What that is just pure marketing. I mean, that is pure marketing to get signed up. And so again, I think it's incumbent on.
So where does the education component
It comes from the providers. It comes from the insurance companies.
It comes from the insurance companies and providers, but there's a challenge in the education that we have to do, because the way the country has chosen to finance this expansion of healthcare access is through tax credits. So we have large populations that are getting access to healthcare now, and they're really not responsible for the cost of buying that coverage.
Right.
So it's hard for them to get and understand the value proposition that's there. You know, if you're given a debit card and says you can go buy anything you want for dinner tonight and somebody else is paying for it, where are you going to go eat? And that's sort of what we've done a little bit with healthcare.
My kids are going to go to Chick-fil-A.
So that's where the conversation goes, and Mike's right, and that's why we were so adamant and insist upon the injection of consumerism. So it's different. Obviously, if you're dealing with somebody who's 50% to 138 of FPL and then on up through the exchange, you know, there are different payment requirements. So what you have to do is adjust the model. Are there things that you can do? Allow them to maybe have sort of a accelerated or enhanced cost sharing where they have more at stake and there be a benefit for them. So that's what we're working on. We've been working on with former Governor Levitt, former HHS Secretary Levitt, on designing our HSA plan here in Arkansas, again, for a population that a lot of people see as just receiving free care. You have to build the incentives right, and then the providers and the insurance companies have to do their part to come along and to do the education piece.
So back to my marketing question here, I guess, instead of an education question, does the insurance company pick up the tab on some of this marketing?
We do.
Will you do more?
I think we'll do more. A lot of it's being web-based right now because that's the way we're trying to make everyone get into the market, is through web products. And so that's where we're doing a lot of that advertising.
Yeah, I mean, I think the big problem too is, and particularly where the insurer is concerned, is the MLR, the medical loss ratio in the Affordable Care Act, which again, we're all now, everyone, all partisan stripes are acknowledging, well, there are some major shortcomings in this law, and they're going to be, you know, I would support a wholesale pulling it out and putting something else in, and have some very detailed ideas about what
Sounds
should
like
go
you're running
in.
for Congress.
Well, I'm not. I'm here in I'm trying to clean up. I'm trying to clean up the mess that they created in Washington and deal with it, rather than going up there.
That even still sounds like you're running for Congress.
Well,
so I'm just giving you some grief there.
I'm staying here. But the truth is, we're going to have to see where we have the flexibility and quite frankly the vision to go in and press back against the federal government. There are numerous things that need to be absolutely redlined in the Affordable Affordable Care Act and done away with, and replaced with things that do give an incentive not only to the payers, but the providers to make value-based decisions about care. And we're sort of in an environment where they're no longer allowed to bill, hospitals are no longer, and providers are no longer allowed to bill for the health care they want to bill for, but they need to provide the care that their patients need, and that's through the changes in income-based care, all those, but we have to go the extra step.
I'll give you the last word on this subject right here. Anything you want to add to that conversation? Although we have the web to talk in perpetuity, I do have to wrap this up.
I guess the only other thing I would say is that David's right that there are a lot of changes that need to be made in the law that would make competition even greater. One of the ones I think that's the biggest problem for the carriers right now is the way that we've been forced to price the products with community rates. That's just a mistake. That's really made it very difficult for young people to get into the marketplace because you have to be able to price at a level that's commensurate with what the consumer feels is the value of the product to them. And because it's been set up to force the younger people to subsidize the older people, the young people don't see the value and they're not buying in the marketplace.
You would lower your rates if you could for that population.
Well, that's what we did in the small group market for years. We started with lower rates. It was a guaranteed issue. Every small employer was guaranteed coverage. We could medically underwrite and raise rates, but there was a cap on how much those rates could go up. And if they had kept that model in place, it would have been much better for the marketplace.
And what the administration now sees is that we don't have participation from younger entrants because, I mean, they can put Zach Galifianakis on TV all day long and they can talk, but the fact is, people, we always say this in the election year, people vote with their pocketbooks. I would also say they buy insurance depending on what they can afford and what they need to do. And the truth is, the way the Affordable Care Act's written, they can hang out there. The penalty's, negligible. And when they do get sick, what happens? They go get it. We have created an adverse selection, which in fact causes rates to go up. So there's absolutely no reason why we shouldn't have, we have gold, bronze, or gold, silver, and bronze on the exchange. The truth is we should have tin, aluminum, and other offerings to get, I mean, if the idea is to get people covered so that they're not going in and hitting the rest of us through higher rates, I mean, then we should be looking at other avenues to get people covered. And the fact is, the Affordable Care Act, I think, Mike, we've had conversations about this. The Affordable Care Act was not a policy document. It was a political negotiation.
Right.
Now we're having to unbundle all of the political negotiation and actually begin to work on policy.
I got to end it there, guys. Senator David Sanders, Mike Stock, QualChoice CEO, thank you both for being with us. And I got to go brush up on my medals to figure out all these new plans that we're going to have. Thanks for watching this Web Extra. You can keep up with the latest business and political news each and every day at talkbusiness.net or on KATV.com. Thanks for watching.